Mr. Vaishnav, and good afternoon, one and all. Today we are continuing with the communication session, second part of the communication. After a gap of 1 week, we are back with the class again, and I welcome Dr. Biju Raghavan sir once again for taking the class. Over to you, sir.
Thank you. Since we all met each other during our session last time, so we can straight away start today's session. Today is going to be a little bit of a longer session because we have a lot of ground to cover. Just let me know in case the voice, if it is not clear or any other disturbance, please let me know. I'll stop, and then if there is any rectification to be done, we'll do that.
Sure, sir.
Yeah. So welcome to all of you, those who have joined for the session 2. I'll start with the screen sharing for today's session. Right. I hope you can see the slide properly now.
Yes, sir. Perfect.
So today we are going to talk about some advanced communication procedures. Why I call it procedures is because communication, any communication, there is an indication, there is a standard operating procedure, and there is an expected outcome out of that. Just like any intervention, any surgical or non-surgical intervention, for that matter, any procedure, for communication also, we have the same criteria. There's an indication for why we do what we do, and for whatever type of communication we plan, there is a pathway, there is a standard operating procedure, and you do it to achieve some target. We don't have time to waste. We don't have time to waste on rambling or talking to people, talking to a patient and family without any rhyme or reason. There is always a target why we do something. So today we are going to cover communicating bad news. Within that, we will talk about some of the models of how it is done, and we will talk about why it is important, the rationale for it. From there, we will divert to another topic called collusion. We will not go into too much detail of that, but we will talk about it a little bit. Then we will come back to communicating bad news, but this time we will talk about how to do it. And last, we will talk about how to deal with the angry situation in our clinical environment. So when it comes to communicating bad news, basically it is truth telling. You tell the information truthfully, honestly. But telling the truth is not easy. It is very hard. And it is a task that most of us don't want to do really. That is why communicating bad news or breaking bad news is a unpleasant job. All over the world, people practice some or the other model of it. In our country and most of the Oriental culture, that is Asian culture, we do not tell it to the patient. Even if the patient has come with the family, we tell the patient to go out of the room. And we talk to the family. Because we don't tell the patient, it is called a non-disclosure model. And we may have our own reasons for not revealing the diagnosis to the patient. However, this can get into a conflict with the patient who wants to know, because the patient may have his or her reasons for wanting to know the truth. So if you practice non-disclosure model, this can get into conflict with the patient's right to know. In medical ethics, the first and the most important pillar of ethics is patient's autonomy, the patient's right. So that is in conflict with your practice of not revealing to the patient. Then there are some countries where they practice full disclosure model. That is, you tell the patient everything, and you can talk to the family only with the permission of the patient, not without the permission. These are mostly Western developed countries where patient's autonomy is held to be sacred. You do not mess with patient's autonomy. You never talk to the family without the permission of the patient. If you do that, you can be sued, taken to the court. And the court will rule in favor of the patient because you have violated the patient's fundamental right of autonomy and privacy. In our country, it is the family which brings the patient to us, and hence the patient autonomy is below the family's right over the patient. So in our culture, individual is not important, the family or the community is more important. In many of the developed countries, the individual is more important, not the family or the community. So in those cultures, they practice full disclosure model, and this can get into a conflict with a patient who does not want to know, because people are different. It's not necessary that everybody wants to know. So if there is a patient who does not want to know for whatever reasons, and if you practice full disclosure model, this again goes into the conflict of the patient's right not to know. So world over, these two models are practiced, non-disclosure model and full disclosure model, and both has a problem. So what is the solution? Solution is a individualized disclosure model, which means that you find out what does the person sitting in front of you wants. Does he or she want to know or doesn't want to know? First find that out. And if the person doesn't want to know, do not disclose the truth. But if the person wants to know, then you have to figure out how much the person wants to know and give only that much information, not less, not more. Less will cause dissatisfaction, more information may cause psychological trauma. So just give as much as the patient wants. So two things: find out whether the person wants to know or not, and then find out how much the person wants to know. So that is in short individualized disclosure model. Now coming to why it is important to communicate bad news, I give you three primary reasons. One, it gives a chance to the person to finish off things that he or she needs to do before they are so sick physically and mentally, so unhealthy that they cannot finish. So while they have reasonable health physically and mentally, if they know that they have limited time, then they will get a chance to finish off many things. It could be the finances, it could be arrangements for the children, it could be about things that you always wanted to do but kept pushing it away because you had other things to take care of. It could be about strengthening the relationships that you have, calling up a friend, meeting, or telling your spouse how much you love her or him, telling your children what you want them to be or how you want them to conduct themselves in life when you are no longer there. It is time to give forgiveness. It is time to ask forgiveness. So there are a lot of things that you can do before you die, but you will get to do those things only if you have been given a chance. And by that, I mean somebody needs to tell you that you have limited time, that you have an incurable, progressive, advanced medical condition. So even though initially it may be shocking, you may go into depression, you may go into bargaining, you may go into anger, but eventually you will settle down. You will come to terms with it. Then you will think, okay, so if my time is limited, what are the things that I need to do? So if you don't give people the chance, they may die without doing the important things, finishing of the important things in their life. The second important point is you can prevent hospital hopping and doctor shopping. Basically, what happens is, except the patient, everybody else knows the reality and they understand whatever you are doing is you are doing the best given the reality. However, the patient does not know what the patient's reality is. But the patient wants to get back to normal life. Who wouldn't want to get back to normal life if they are sick? Everybody wants to be, you know, everybody wants to get back to their normal life. So, from your point of view, the patient has unrealistic expectation. But from the patient's point of view, patient just has ordinary realistic expectations. The difference is the patient does not know his or her reality, you do. And therefore, there's a reality expectation mismatch. And because you can do the best realistically, you can never reach the patient's expectations. And as a result, the patient will soon realize that you are not capable of providing the patient what the patient wants. Soon the patient will get frustrated and thereafter patient will lose faith and trust in you. And the patient will demand his family, take me to some other place. This place is not good. They don't know anything. And the family will be forced to take the patient to a new hospital or a new place out of city, sometimes out of state, or even out of the country. And all of this involves spending a lot of money, it involves traveling, it involves a lot of physical, emotional, financial suffering. And for what? There is really no treatment available. So the patient goes to a new place, the patient's hope rises, then the patient's hope crashes. And this continues on and on. So that is what is meant by hospital hopping and doctor shopping. Remember, if you are living outside your home, you have to spend money even for drinking water. And because the family is not able to earn, because the family has to go with the patient, the family ends up selling whatever they have, eventually selling the roof over their head, their house. And this leads to lot of poverty, medically induced poverty, and many a times it is because the truth was not told. The patient dies, the family is on the road. And somewhere we have to understand that we did not do what we should have done. That is, tell the truth, tell the bad news. Another reason why it is important, the third important reason why it is important to communicate bad news is because since the patient has not been told the truth, the family has to act as if everything is normal. They put on a mask as if everything is normal and they behave like that in front of the patient. When the emotions overwhelm them, they'll go to the father's room, get into the bathroom and cry, and then wash their face with water and come back and behave as if everything is okay. They will go to the relative's house and cry. They will go to the neighbor's house and cry. They will come to the hospital into our consultation room. They will cry, but they can never cry in front of the patient. Now, patient also understand that something is terribly wrong. Even if nobody is telling the patient the truth, the patient's body is telling the patient that something is terribly wrong. The patient may not know the name of the disease or the prognosis. The patient may not know the information, but the patient knows I'm not getting better. I'm becoming worse and worse. So patient knows that there is something terribly wrong, but patient also knows that nobody is telling the truth to me. Patient sees that relatives from far away are coming to see him or her, and patient can hear whispers in the corridor in the next room, and the patient knows that they are talking about me, but nobody is talking to me. So the patient feels as if I am all alone. Everybody is on the other side. They talk to each other, but nobody talks to me. And if at all, people are not talking the truth to me. So this kind of barrier is there in many households where the patient has not been told the truth. And eventually the patient dies, and the family members look at the photograph of the patient with a garland around the photo and wishing only if I had some more time. The question is, what were you doing when the patient was alive? That time you were playing a drama, and now you wish the patient was alive for some more time. So that is the paradox. So that is the barrier in relationship, and this happens because we did not make an effort to tell the truth, because truth telling is painful, truth telling is difficult, and nobody really teaches us how to tell the truth. So the three reasons why it is important to communicate bad news, but we all understand that even if we wanted to, many times the patient's family prevents us. They will come and tell us, please don't tell the patient. Please don't tell the truth. Now, this is called collusion. When the family members come to us to conspire, to enter into a conspiracy of silence, please keep the information away from the patient. You can talk to us, you can tell us the truth, but don't tell the patient the truth. Now, why do family members do this? Basically, they're trying to protect their loved ones from the bad news, from the truth. And who has the information? We, the healthcare professionals, have the information. So the family is very anxious that we may tell the patient. They can't avoid us because they need our services, but at the same time, they are afraid. They're afraid of us because they think that we may purposefully or accidentally tell the truth to the patient. And they are trying to protect their loved ones from this. Now, we are scientifically trained people. We know that telling the truth has many benefits. We know that truth should be told only to the person who really wants to know, not to those who do not want to know. We know all of that. But people have beliefs. They believe that the moment you tell the bad news, the patient is going to have a heart attack and is going to die immediately. And most of the popular perception is like that. You see this in movies, you see this in serials, that if something is told and then the person suddenly collapses, and these kind of images we see, which is not the truth as far as if you look at it from the scientific point of view. But people have their belief, and for them, their belief is real. Therefore, if you tell them, no, 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 it is nothing like that, it's very important to tell the truth and all, you are only going to increase their anxiety. And they may get so scared of you that they may even take the patient away from you because they are so scared. They think that you are planning to tell the truth. So do not challenge their belief. Instead of that, you agree to collude. So if they say, please don't tell the patient, you say, okay, fine, no problem. I will not tell. In fact, in my day-to-day practice, I also ask, so what have you told? So just recently, there was one family member who told me that his father, who has cancer of the stomach, he told his father that he has TB, tuberculosis, and for that he has to come and take medications. He did not say chemotherapy, he said medications. So people can tell all kinds of lies to their loved one to try to protect them from the truth. So from as healthcare professional, the first step is to bring down the anxiety of the family member, bring down the fear of the family member, and that you do by agreeing to collude. Next step is to earn the family's trust. For that, you listen to the family. What are their beliefs? What are their fears? What are their concerns? What is their story? You listen to them and build up a relationship. So all the things that you learned during last time, active listening skills, those are the tools that you will need to build up this relationship. Apart from that, in when we are learning the principles and practices of palliative care, the main focus is to relieve the patient's suffering, especially the physical suffering. If you take care of the patient's pain, breathlessness, restlessness, whatever, then if the patient is happy, the family member is happy, and the family member starts trusting you. So apart from listening to the family and building up a relationship, taking good care of the patient will fast forward the family trusting you. So this is how you earn the trust of the family. And once you have earned the trust of the family, Now they start listening to you. They will believe you because they trust you. This is the stage where now you can reorient the family from their belief that the patient should not be told the bad news. If you tell the bad news to the patient will be harmed. All of their beliefs now you can reorient because the family has seen how well you are taking care. The family has no problem trusting you because they have seen how you mean well for the patient. And this is the point where you reorient and talk about the chance of finishing things while there is still time, preventing hospital hopping and doctor shopping by bringing the patient's expectation to reality so that the patient understands what you are doing is the best that is realistically possible. It will also remove the barriers and an ability for the family to hug their loved one and cry at least. That opportunity will be there for the family as well as for the patient. So there are a lot of things, a lot of positive outcomes. There will be a chance to make memories, to take pictures, to take videos, and these kind of things will happen only if the truth is out there in the open. So this kind of reorientation of the family you can do once you have earned their trust. But remember, initially you will have failures because like any new skill you learn, you are not an expert. You are a physiotherapist, you learn a new technique. Initially, you are not an expert, and you see somebody who is an expert getting good results. We may not be getting good results in the beginning, but as we practice, we get better and better. You will see your ability to reorient the family, your ability to convert the thinking of the family will improve. So initially there will be a lot of failures, success rate will be less, but gradually the success rate will improve. However, it will never be 100%. You can be the most skillful communicator, counselor, but you will never have 100% conversion rates. There will be always family members who will not agree. And if you see that you have tried your best and the family is not agreeing, then you leave it. Do not make it your agenda that you have to convert the family. That you have to, you know, manage the collusion because only then you can communicate bad news to the patient. So without the family on your side, you can never communicate bad news to the patient because then you will get into trouble. So it's always important that you get the green signal from the family, only then you communicate bad news to the patient. For that, collusion management is important. However, it is very much possible that collusion may persist. The family will not allow you to tell the truth to the patient. So if you have tried and then failed, there is no shame in it. The only shame is in not trying. So be prepared for failures. That is perfectly fine. Try, fail, no problem. But try. So if you're able to make the family see the importance of communicating bad news, you have managed collusion. Then you can reach the patient. And for that, you have to understand the standard operating procedure of communicating bad news. It is called Spikes protocol, internationally recognized. Remember, we don't have internationally recognized SOP for collusion management, because collusion is not a universal phenomena. Collusion is there in certain cultures, especially the Oriental culture. Therefore, what I just mentioned regarding collusion, first agree to collude, earn the trust, then reorient the family, and try to uh, manage collusion. That is the SOP for collusion management. Whereas Spikes protocol is a universal SOP for communicating by bad news. S stands for setting up the interview. Assessing P stands for assessing the patient's perception. Basically, trying to find out what does the patient know about his or her disease condition. Then I stands for invitation. That is, we need to have the patient asking us, I want to know about this. Then knowledge. You share the information honestly. And when you share it, be prepared for emotions. And you should know how to deal with emotions. And once you have dealt with emotions, then you can do the strategy, planning, etc., and then summarizing it. So basically, that is the Spikes protocol. So we had Mr. Bharat, a 60-year-old gentleman who had a traumatic brain injury following a fall. The neurosurgical interventions was done. Uh, Post-op GCS was E4V1M1. The neurosurgeon counseled the family about successful surgery and thereafter referred to the physiotherapy department. The family, that is Mr. Rajesh, who is the son of Mr. Bharat, he expects the patient to make full recovery because the neurosurgeon told that the surgery was successful. But your assessment after a certain period of time, you are physiotherapist, I am not. So I'm not going into the details of it, but your expert assessment over a period of time, you have come to a conclusion that the patient will not have any improvement. Now, this is something which we will call a bad news. So this is something that you need to convey. Here, the patient is not in a position to hear the bad news. So here, the situation is that you have to convey the bad news to the family. So here we'll try to understand what is the family's insight. So when you talk to the son, Mr. Rajesh, so this is what the patient's son says. My father fell down from the stairs and he hit his head and he became unconscious. We immediately took him to the hospital. So there they did a CT scan and they showed there was a bleeding inside the head. So the surgeon came and an emergency surgery was done. The surgeon told us that the surgery was successful. And thereafter surgeon said that rest of the treatment is by the physiotherapist. So nowadays he his eyes are open, he looks at us, but is not yet speaking or moving. I know that he will make full recovery, he will come back to normal. My only question is how long will it take? So this is the son. So basically what the son is expecting is unrealistic, because the patient's reality according to your expertise is patient will not have any improvement. So now how do we go about it? So you have to prepare for this procedure called communicating bad news. You should know the medical situation. You plan for this. We don't do this on the standing in the corridor. You have to have a place where you can sit down with people and then talk. If you have some water to drink in paper cups and things like that, great. Use active listening skills that you participated in last time. And first, explore. I've written if patient wants, in this case, it is the son. Mr. Rajesh, you asked me how long it will take. Would you like to know more about your father's condition? So this is an exploration. And if Rajesh says, surgeon said the surgery was successful. Is there any problem? Now you have to give a warning shot. Mr. Rajesh, if it is something serious, would you really want to know? Now, this is important because when you have a warning shot, then those who are not mentally prepared to hear the truth, the bad news, they will back away. They will back off. They will back off by not making eye contact, or they may say, or they'll change the topic. Let us continue the physiotherapy. I don't have time now. Maybe we can talk later. Or they may tell you, no, no, I don't want to know. So body language is a big clue, because last time we learned that the major part of communication, any communication, is body language. And if there is no eye contact, or the person is not meeting your eyes, that means the person is not prepared to hear the bad news. Do not proceed. Whereas if you have somebody like this, looks into your eyes and says, yes, I want to know, no confusion. Here is a person who really want to know. Proceed with communicating bad news. So warning shot is the place where you will differentiate between a person who wants to know and does not want to know. This is the first requirement of the individualized disclosure model. You have to find out whether the person sitting in front of you wants to know or not. The warning shot is the tool which will help you decide the person sitting in front of you whether the person wants to know or not. Now you can proceed. If you have a person who wants to know, then you tell the story. If it is the patient, you tell the story of the patient to the patient from the beginning. If it is the family member, you tell the story of the patient to the family from the beginning. And while you're telling the story, you fill in the blank spots. You have talked to the family, you have understood what they understand, and in it, you will realize that they have some blank spots. They don't understand few things, they misunderstood a few things. So while you're telling the story of the patient to the patient or the family, you fill in the blanks as you go along. And as the story proceeds, you escalate the intensity of information. You give more and more higher information as you go along. While you're telling the story, if the person sitting in front of you stops making eye contact, you pause the story there, because either the patient has got new information and the patient or the family member needs some time to digest, to process this new information. And once the patient or the family member has digested this new information, the person may look back, make eye contact, so that you can proceed. If it's a long pause, you don't know what to do, it is becoming uncomfortably long, you don't know whether the patient or the family member is still thinking about it, or if they had enough, we don't know. So you can break the pause, the long pause, by saying something like, do you want to know more, or what are you thinking? Something to break the long silence. And if they continue not to make eye contact, if they continue not to respond, that means they had enough. Or if you have broken the silence and they look back at you, then you can continue the story. Stop where the patient or the family member wants you to stop. So in this way, you will ensure that you are giving the optimum quantity of information, not less, not more, as much as the person wants to know. So a small role play. for all of you. Mr. Rajesh, your father suffered a major head injury in the fall. Yes, your surgeon did save his life with the surgery. However, the damage to the brain has been severe. Oh, also the damage is permanent. Despite the best possible physiotherapy, he's unlikely to get back to how he was before the fall. Do you mean to say he will never get up? I am sorry. Yes. Mr. Rajesh, do you have any more questions? The surgeon said the surgery was successful. Then why he won't recover? I don't understand this. The surgeon is right. But what he means by successful surgery is that your father's life could be saved. But there is too much damage for the kind of recovery you were hoping for. Now, you see, finally, the person in front of you understood, and now there is emotion. When somebody starts crying or expressing emotion or sitting numb without saying a word, you have to allow the emotion to be ventilated. From your side, don't do anything, don't say anything, just be with the patient. Just your presence. At best, you can touch the person on the shoulder. Don't tap, don't pat, just touch for a moment and then take your hands off. Just wait for the patient to get control of his or her emotion. It will take some time, but it won't take a lot of time. Usually, people get their emotions under control in a minute or two, not more than that, sometimes within seconds. So, you have to wait for the person to cry, and this is the time where you can place the glass of water or a paper cup of water near to the patient or a paper napkin near to the patient. You don't have to give it in their hands, because if you keep it near them, then they have the choice to take it or not to take it. So just show them that the water is there. You push it towards them, but don't force it upon them. And just silence, a silent companionship of your presence. That is what is required. Don't say anything, don't do anything. And once the emotions have been ventilated, the person comes back to you. And then you can, comes back to you in the sense that looks at you, and then you can talk about what can be done, what cannot be done. So in this particular case, you can say, okay, the recovery is not possible, but we still have to continue physiotherapy so that all the joints are supple, they are moving, so that the care is can be continued. Otherwise, if this we don't do, then the limbs can go into contracture, then care and hygiene will become difficult. So you can then talk about what can be done realistically and what all needs to be done. So there is no situation where nothing more to be done. There is always something to be done. So give realistic hope of what can be achieved. Never give unrealistic hope. And this is how we will finish the story. If you have any questions on either pollution or communicating bad news, you can start putting up on the chat, and we will take it later on. We come to the last topic for today, which is about managing anger in our clinical environment. Remember, we are not talking about law and order situation here. We are talking about managing anger in the clinical environment. What is a law and order problem? A mob violence, a group of people indulging in violence is a law and order problem. We are healthcare professionals. We are not trained in law and order management. So if you are faced with a law and order problem, you run away from that place because you are not the expert of dealing with them. Another example of law and order problem is people are under the influence of alcohol or other substances becoming violent. You cannot have a conversation with them. So those are not the things that we are talking about. We are talking about day-to-day anger situation in our clinical environment, which can get out of hand if we don't handle it in a professional manner. The day-to-day anger sometimes can get into a law and order problem. So it's very important to manage it in a professional manner. So basically, anger is an emotion. It's a negative emotion, and it consumes a lot of energy. So it's a high energy consuming negative emotion. Now, nobody wakes up in the morning and says, "Oh, I haven't been angry in a long time. Today I'm going to get angry." Because it's a very unpleasant experience being angry or facing anger. So nobody wants to be angry. The problem is lot of stresses. Anger comes because of multiple etiology, multiple sources, and it just builds up the stress, and so much so that it ultimately bursts out at a certain point of time. And many a times, we as healthcare professionals are at the receiving end because people come to us not because they want to come to us. They come to us because they don't have a choice. They come to us because they are sick, they are not well, they are ill, they are suffering, they are in pain. Their normal life has been disrupted. And hence, our interaction with the patient and family, the starting point itself is a negative. That is why in our healthcare profession, we face so much of stress, unlike those who are running a resort or a hotel or a cinema theater. They also face a lot of stress, but at least people go there, spend money because they want to. In our case, people come to us not because they want to, but because the situation made them come to us. So naturally, when people are not in the best frame of mind, they are stressed out, they are uncertain, they're in unfamiliar surrounding, they wish they were not here. It is easy to get stressed out, and it can come out as anger. And most of the time, we as healthcare professionals have to deal with it. So, first of all, it's a high energy consuming negative emotion. So, if you remove the energy supply, you can deal with it in a better way. So, imagine if somebody is very angry, what can increase this person's anger, or what can sustain this person's anger? Primarily, there are two types of fuel. which can increase or sustain anger. One fuel is confrontation. If you argue with this person, if you talk back, if you make eye contact, very angry, and you apologize to that person, that also becomes confrontation. Your apology may make the angry person even more angry. So anything and everything can potentially become a confrontation. So that is one category of fuel which can increase and sustain anger. The another category of fuel is ignoring the angry person. You don't make eye contact. You turn your back towards the angry person. Maybe you're feeling scared. That's why you don't want to, face up to this person. So that ignoring an angry person will make the angry person more angry. So that is another type of fuel. Primarily two types of fuels: confronting and ignoring. So if we do either of it, we will sustain this anger or increase this anger. So here is a person who's angry, talking or rather shouting in very loud voice. The tone of voice is angry. The choice of words are very, very uncivilized. And look at the facial expression of the angry person. There is eye contact, there is aggression on the face. And usually, an angry person will not be sitting and getting angry. There is so much of adrenaline, the person cannot sit. The person will be standing or walking around. So, that is the typical situation of an angry situation in the clinic. And if you are the person there, remember, neither confrontation nor ignoring will solve the matter. You have to facilitate the flow of emotion. Remember, anger is just an emotion. So, like any communication procedure, body language is very important. Many a time, when an angry person is there, we remain seated and we don't want to make eye contact with that person. And that will make the person more angry, because when you remain seated, your body language is communicating hierarchy, because the angry person cannot sit down. The angry person is in so much of anger, that person is standing or pacing around, walking around. And if you remain seated, it will create a hierarchy which says, I am superior, you are inferior. So you stand up and your body language is showing we are equal. The standing up position shows equality. Then stand respectfully. Respectfully means a slight kyphosis when you stand. This shows respect. So I see you as my equal. I am respectful towards you. And keep the hands where the angry person can see, preferably in front of your body, because you are conveying, I am not going to attack you. You can see my hands. I am not a threat to you. I am not going to attack you. So this is psychology. Your body language is conveying so many things without you saying a single word. So this is your body, this is your face. You make eye contact. When you make eye contact, you are conveying, I am not scared of you. Not in an arrogant manner, in a polite manner. You are showing, I am confident. And if you are confident, that means you are not scared. Inside, you may be scared, but when you make eye contact, your body is conveying the message, your body language is conveying the message. I am confident. I am not scared of you. And maintain a serious face. Usually we say smile. In this particular situation, we say do not smile, make a serious face, because here you are saying, I am taking you seriously. Whatever you are saying, I am taking you seriously. And just like you learned in active listening, nod your head. Nodding the head encourages the person to speak. The more the person verbalizes, the more emotion is coming out. So you are encouraging ventilation. So you are not providing fuel. You are neither confronting nor ignoring, just by your body language. And you are encouraging this person to ventilate the anger more and more and more. So no fuel supply and faster ventilation of anger, the anger starts coming down very fast. Within seconds, the anger starts coming down. So now the tone of the voice may still be angry, but comparatively less anger. The volume of the voice is still high, but comparatively it is less high. And now the gradually the bad words, the uncivilized words also come down. And now they are more of a complaining nature than of a threatening nature. So gradually the anger is coming down. Now that doesn't mean it cannot go back to high anger. It can. But if you maintain the body language, the body and the face, the body language, that will bring the anger down. And once the anger has come down sufficiently, you can see the body of the person is more relaxed. He is not pacing around. The face is now relaxed. The tone of voice has become more neutral. The volume of voice. Earlier, he was shouting at the top of the voice, but now the volume of the voice is almost near to normal conversation volume. Maybe a little still higher, but still much lower than what it was. And then this is the good time to invite this person to sit and talk. Sir, I want to know more about this. Can we sit down somewhere and talk? Do not invite the person to sit down and talk when the person was in high anger. You bring the anger down, then invite the person to sit. Basically, you are saying, "Ye dil mange more. I want to know more." And then you can sit and talk, and you continue the same strategy with your body language, except that this time you are not standing, you are sitting with this person. That person is also sitting, you are also sitting. And here you say you are sitting with a slight kyphosis, a slight bend forward, which is conveying that I am here to listen to you. And then you continue nodding the head, and then you find out the story. What exactly got this person? So this you will get to know if you just allow this person to ventilate. The person will tell you why, what all happened, and then if there is a solution, if you can resolve, you can do that. Offer a solution if it exists. If there is no solution, you don't have to give a solution. Sometimes people get angry for things for which there is no solution. If an apology is merited, only then apologize. Do not give an apology for the sake of apology, because immediately it will be known that this apology is not sincere, it is insincere. So don't give an apology for the sake of apology. Give an apology only if it is really required. Example: thank you for bringing this to our notice. We are very sorry you had to experience this. So this is an apology. Another example: thank you for bringing this to our notice. This is what we will do. You can tell what you are going to do so that something like this doesn't happen again. See, there is no apology here, but here you are telling what you plan to do. So basically, if you really think an apology is required, you can give an apology. If you don't feel an apology is required, you don't have to. Most of the time, you will realize that the family member will end up apologizing to you for creating a scene. This happened to me. This happened to me very often. But the last happened to me was 3 days ago, when a family member got very angry, and I was fortunately there. I could divert this. Now, if we know the standard operating procedure for anger management, focus on the body language. You do not give the fuel to the angry person. You allow controlled ventilation of the emotion, and then you get the person to sit down and then ventilate more, ventilate more, ventilate more, ventilate more. That is the simple way of managing anger. So take home points: when it comes to collusion, the most important thing is listen to the family. When it comes to communicating bad news, remember, you are only a facilitator of information. The patient or the family will decide how much they want to know, if they want to know. When it comes to anger or difficult emotion, allowing them to ventilate the emotion is a therapy. It is not a waste of time. And non-confrontational active ventilation of anger is an easy skill to master. Of the three things that we talked today, the easiest is managing anger. The next difficult is communicating bad news. And the most difficult is managing collusion. With this, I will stop here. And I saw somebody raising a hand. And if there are any questions in chat, if the Palim India team can take the questions and convey to me, I'll be happy to answer.
Thank you, sir. Thank you so much for that very elaborative session as usual. So we had one question from Mr. Tarun. Mr. Tarun, would you like to say specifically, like it's a case by case and depends on reciprocation of patient or family members? Maybe if you could come in and say a little bit more about that. You are not audible, Mr. Tarun. No, still not audible. Maybe you can try removing your headset and then. Not audible. No.
Unmute it.
In the meanwhile, if anyone else have to put in any comments, queries, suggestions, Mr. Tarun, we would request you to keep trying because your voice is not at all audible.
Can you hear me now?
Yes, perfect. Please
sorry, some technical error on my side. Thank you, Dr. Biju. Really very interesting and quite a lot of new notions I come to know. So thank you for that. The question what I had is this, that in case there is a subjectivity that a patient may or may not be ready to listen or accepting the news, they may say that, like, okay, the command you said, would you like to know more? Or second thing, if they want to know but they are in denial, how you handle this type of cases? It will be a bit subjective, is it?
Today's classroom session is basically giving you signpost. This is the direction. These are basically direction. Every patient that you deal with will be different, and you have to deal with each patient's situation on the merit of the case. So if we are talking about a person in denial, then it's a different subject matter altogether.
Oh, okay.
For example, what is denial? Denial is a psychological protective mechanism which people adopt because they are faced with something so fundamentally traumatizing that they go into a state of denial because it protects their sanity, and it provides them support like a crutch for a person who has an injury to the leg. The person can walk with the help of a crutch. Similarly, you can move on with denial. But just like a crutch may not impede the management, similarly, a person in denial may not, the denial may not be a barrier to what you want to achieve. And if that is the case, then you don't have to bother about the denial at all. You need to break the denial if it is becoming a barrier to what you want to clinically achieve. And then how you go about breaking denial is to sit with the person. I mean, until and unless you don't have the trust of the person, you can't do most of these procedures. You need to have the patient listening to you. So earning the trust is the first point, and then listening to them. Why are they in denial? And then going about it. A lot of time, these kind of things take a lot of time, and you can't ever be sure that you will be able to reach where you want to reach. And if you will reach that point completely or partially, whether it is denial or collusion management, or even communicating bad news, or even anger. I'm just giving you the scenarios and the signposting of this is how we go about it. Each individual that you are going to deal with, just like in physiotherapy. I mean, you learn physiotherapy, but you have to adapt what you learn to that individual person, the person's social support system, the medical situation. Everything will be unique for that person. So does that answer your question?
Yes, very well. Thank you, doctor. I appreciate it. Thank you.
Thank you for the question.
So we have one more question from Mr. Murugavel. How supportive hospital environment or organization to the doctors or healthcare practitioner in providing the fact to the patients? Since business model is a barrier for many healthcare practitioner to involve with giving facts to the patients or patient family.
I guess these concepts are something that needs to percolate down. See, whether we are doctors, nurses, physiotherapists, or administrators, we are coming from the same society which has this kind of mindset. And how are we going to change the mindset? We all need to individually practice this, and we need to teach others. Just like I'm here taking a session for you. Somebody taught me these things. It didn't come to me automatically. Somebody taught me. And after teaching me, somebody mentored me. And I, with teaching, mentoring, I became better. Now I'm teaching others. And I'm not teaching only physiotherapists. I'm teaching nurses. I'm teaching doctors. I'm teaching non-medical professionals. these concepts. So gradually we will make a change. See, for the major part of human awareness, the earth was flat. Nobody thought earth was round. Earth was flat. It was the truth. For millennia, many generations of human beings were born, they lived and died believing that the earth was flat. One person said, earth is round. Nobody believed. Then that person taught another person. Gradually, over many generations, societal attitude changed. Now we know earth is round. We all believe earth is round. Nobody has to tell us, we know. Similarly, these concepts that telling bad news is bad, this idea of protecting the loved one from bad news and engaging in collusion, our helplessness in how to deal with anger, because nobody taught us what is the standard operating procedure of dealing with the angry person. We have this attitude of seeing the angry person as a villain, see that angry person as a victim, the victim of a situation. So much of stress, so much of pain that the person gets angry. I said, how many of you will wake up in the morning and say, today I'm going to get angry? I have not been angry for a long time. None of us want to get angry. It's a very traumatic experience becoming angry. So we have to stop looking at people who are angry as villains. They are victims of that emotion. And we should have the skill of draining that emotion, get them back to sanity. And I have told you how it is done because I do it every day, or not every day. I do it very often because I don't confront anger. I do not turn away from anger. I facilitate anger to flow, just like you do ascitic tapping. When you put in a needle and the fluid flows down in a controlled way along a tube, and once the tummy shrinks, all the fluid is gone. The patient is comfortable. Similarly, you do a anger tapping for the person full of anger. You tap the anger, allow it to flow. The anger all flows. The person comes back to sanity, and it is good for us also. It keeps our sanity. It keeps us protected. So these kind of skills are very important. It is not very hard to learn. It is not hard to practice also. So it's a combination of things. Some things will take time. Some things you can learn fast. And we all, I hope you have learned it. I hope you will practice it. I hope you will talk about it. And if you become skilled, hopefully you will teach others. You will be there in my place teaching this to your colleagues and others around. Hope
Thank
that
you.
answers your question.
Yes, sir. Thank you. Thank you for your valuable comments on that, sir. And if participants need any more answer, if you have any doubts, you can put it on chat box or in our WhatsApp group. And now it's time to move on to the case presentation. Today, we have a case presented by Ms. Gargi Kulkarni. And over to you, Gargi, for the case presentation.
Thank you so much. Thank you, sir, for a wonderful presentation. And I wish all the women out there very happy Women's Day. And can you please share my case? Yeah, thank you. Next page. So this was a 23 years male patient with Ewing's sarcoma or PNET with multiple skeletal metastasis, and he got admitted at our centers. Metastases were present at right femur, left ilium, L1, L2, L3 vertebral bodies. Next page. So presenting complaints are bedbound patient, low back pain, loss of sensation below low back, loss of movements of bilateral lower limb. Next, please. So HOPI. So this was a known case of Ewing sarcoma or PNET, diagnosed on 31st of December. Right presacral mass biopsy was done and it was found to be malignant round cell tumor. And pathophysiology reports were consistent with Ewing sarcoma. He received all 8 cycles of chemotherapy with VSCI regimen in the month from March to November 2021. Also received conventional radiotherapy to involved area with a total dose of 5600 in 28 fractions. And to left iliac and right femur and L1 to L3 vertebral bodies also he received conventional radiotherapy from April 2021 and to May end in a private hospital. Had a features of spinal cord compression on 2nd of January this year. That is loss of movements and sensation below low back, and then patient admitted at our center for further palliative care. Next, please. So examination, we did bilateral range of motion. Bilateral upper limb was full. Bilateral lower limb, we checked it with passive ROM, which was full. MMT for upper limb was grade 4 and lower limb for grade 0. Loss of sensations below lower back. He had a pressure sore. Location was at sacral region, 5 by 5 centimeter, and the stage was stage 4, that is full thickness tissue loss with the visibility of bone. Next page, please. Yeah. So treatment protocol was wound care and dressing was done by nursing team. And in physiotherapy, we were looking at his positioning, like 2 to 3 hourly change in positioning with properly help and support of wedge cushion. Then bracing, we tried using Teller's brace, but it was very uncomfortable because he had a pressure source at low back. So we stopped using that. And in exercise protocol, we started with active ROM exercises and strengthening exercises for bilateral upper limb, passive ROM exercises for bilateral lower limb, and breathing exercises. As he was bedbound patient, his lung capacities were reduced. So we used to take that also. Next page. Psychosocial, in psychosocial aspect, patient was aware that he was suffering from cancer and he understood the seriousness of cancer. The mother does not want to tell him the prognosis of the disease because she was alone with the patient as a caregiver, and she was not able to handle his emotions. And he wanted our support because he was not aware of prognosis, and he was thinking that he will recover someday, and he wants to walk and he wants to do something for his family. So that was his main concern, when I will be able to walk. Next page. So I guess we don't go into much of the details with medications, but he was on gabapentin, clemafene, neosporin powder for pressure sore. Then for pain management, he was on tablet morphine. For edema reduction, like the spinal cord edema reduction, he was on Dexa. And Levopril, as he used to get convulsions in between. So Levopril was also on the medication list. Next page, please. So main concerns in physical, the main concern was back pain, paraplegia, wound at sacral region. In psychological, he was very anxious patient. He was very depressed. Like every time we used to visit him, he used to say, when I will be able to walk. So he was very anxious and very much depressed and worries about recovery, like how much time will be required for my recovery. In socio-economic factors, he is very young patient and family, like his mother has already spent a lot of money on chemo and radiotherapy, and he wants to do something for family. In spiritual aspect, he used to ask every time, why can't I do exercises like other patients? Because whenever we used to go in ward and we teach different exercises to different other patients, so he used to say, ma'am, ये मेरे साथ आप कब start करोगे? मैं मेरा lower back का strengthening कैसे करूँ? और मुझे exercises बताइए ताकि मैं चल सकूँ. So these were his common questions. And when will I be able to walk and do something for my family? This was his main concern, which our medical social workers also found the same thing. Next page. So in short, this is a case of 23-year-old male patient diagnosed with Ewing sarcoma or PNET, currently bedbound with paraplegia and pressure sore at sacral region, and is not aware about his prognosis of the disease, and he is hopeful that he will be cured one day and he will start walking soon. So I guess a few questions sir already has given answers, but I'll just read out for all of you. So patient is aware about the diagnosis, but unaware about the prognosis. And his mother doesn't want to want us to tell him about the current condition. And patient keeps asking us questions like, when will my legs move? When will be able to sit without support? When will be I able to stand and walk? Why don't you give me other exercises or more exercises so that my back becomes very much strong? So these questions used to come from his side. So my questions are, what are we supposed to tell this patient and how about his prognosis, and how to communicate and convince his mother for doing breaking bad news to the patient?
Thank you, Gargi. Thank you for the wonderful presentation. And coming to the discussion points, I request our participants to come up with some nice ideas or some comments on these questions.
So like if they were in this, but they were handling this particular patient, if you had this patient in your settings, how would you be planning to handle? You can either unmute and speak, or you can put up your comments in the chat box.
So I guess sir has mentioned in his presentation that if relatives, like if there is a collusion between the telling prognosis to patient or not, so if relatives are not wanting us to give the prognosis to patient, then we need to stop. We are not supposed to talk furthermore. So this thing I got, but still patient keeps asking us questions like that. So sometimes we have to answer him. So my question is that how are we supposed to give answers? Because patient is already anxious, patient is already depressed. So if we, talk very clearly without giving false hopes or very straightforward, if we do that, so that can create more depression and anxiety in patient.
Yes, Dr. Mani.
Monica Saxena has raised her hand. Please unmute and speak here.
Good evening, everyone. Since according to this case, what I feel is when we ever encounter a patient with neurological deficits, so it's very hard for us to explain to the patient the correct prognosis for the rehab process he have come to us. So it is one of the common questions with the neurological patients asking when we are able to walk, since according to this case, the patient is quite anxious, the mother has not disclosed the prognosis to the patient itself. So it becomes quite difficult for us. So giving vague answers should not be there. We should not give vague ideas. Yes, you'll start walking within 2 months, and probably none of us does that. So it all depends upon the patient's willpower itself, how the patient is going to respond to our rehab protocol, how the patient is working on it, how we are working on the motor deficits the patient is having. So we should never give the vague ideas, or we should not communicate in a way, yes, you will start, because when we talk in a yes way, so it is a confirmation to the patient that he is going to walk as soon as possible. And this is what most of the neurological deficit patients do ask every time they come for rehab, when we'll be back to a normal life. So this is what I feel. No confirmation should be communicated by our side. So it all depends. It's a two-way process, the rehab process also, and the patient's own willpower also. though sometimes we encounter certain situations that we have to explain them that it will take a long time. So by the end of the day, it's all the rehab protocol that we are planning. We are changing it day by day according to the improvement in the deficits. Thank you.
Thank you, Manika, for your valuable comments on that. And we have one more session on our chat box. And Haribabu has messaged that paraplegic patients who have gone better rehabilitation should interact to fresh patients and bring hopes. They can start a WhatsApp group to communicate. As of course, as Haribabu mentioned, it will be a good idea to get some funds or to get a groups of people like him to make communicate with him. And
I just wanted to mention one thing, like a paraplegic patient with grade 4 pressure sore. You can just imagine, and he's just 23 years old. So what happens, the survival period is very small in these cases, and they have the hopes because of the age factor. So sometimes it is really critical to explain the patient about the prognosis, and there is a very limited scope for us to work rather than just maintenance program, the rehabilitation program, because we know that the paraplegia is not going to reverse in his case. What happened, I'll just mention. So in between his tenure in our center, he had developed motor weakness in his left upper limb also. So with the physiotherapy and exercises, that got recovered within 3 to 4 days. Like he really got good power in the left upper limb with the exercises. So he was very hopeful with that. So he thought that abhi mera haath acha ho gaya, now my legs also will start moving. So sometimes small symptomatic relief also increases the patient's expectations.
So one thing we can do about this case is like you can give some psychological counseling to this patient's mother to making her understand the importance of exploring the or opening up with the patient. It will be a good idea for giving a counseling to his mother. Then you can look into this patient's physical, psychosocial aspects and other aspects.
Can I say?
Yes, go on.
Thank you. Maybe we have to see also the prognosis, how bad and good is the prognosis, because having sarcoma may not have always a good prognosis. If it is on the bad prognosis, and you are telling that a patient also developed something on the upper limb weakness, was it a metastasis or was it?
Yes. No. Not for upper limb. He had,
I mean, like in the spinal cord.
He had a skeletal mets at left ilium and right femur and vertebral bodies L1, L2, L3. Nowhere else.
I mean, when he had developed the weakness in the upper limb, was it due to metastasis in the spinal cord? Was it the compression was because of that?
No.
Then it was because of the diagnosis.
We didn't invest it after that. After patient got admitted, we didn't send the patient back again for PET scan because it is very difficult to carry the patient just for the PET scan. So we didn't send. And he was admitted mainly for wound management and pain management at our center.
Yeah, so that will give him hope, and his family member also. Okay, it was. So you have the conflict, how to handle like, yeah. But yeah, it's better to say because he's a young guy comparatively. So we need to break the silence. Because the prognosis is what is the basically the prognosis, if you allow me to ask, the prognosis is turning out to be.
I didn't get your question.
Was the discussion on the prognosis, how well the prognosis will be of this particular patient?
Prognosis less than 6 months.
Less than 6 months. So we need to break the right? Because he has to settle, like as Dr. Biju suggested us, and has shared, and family member also have to accept. But of course, it depends again on whether same what he suggested, what he discussed, depends on the place, culture, and health system. Are we allowed to or not? Yeah, interesting. Thank you. Thank you, Doctor.
Okay, thank you.
Mr. Kumaravel has commented that we have to tell about the possible outcomes of rehabilitation, what he gained compared to previous, then build up from early gains. So, would you like to explain or throw more light on it, Mr. Kumaravel?
I guess yeah, please go ahead.
Hello, excuse me. Hello.
Yes, sir, you're audible. You can speak up.
Hello. Hello. Can
Yes,
you
sir.
hear me?
Yes, sir. You're audible.
Hello.
You're
Yes.
audible, sir.
No, actually, there is some improvement in the patient. Yes. Actually, there is some improvement from the patient. Initially, they may be bedridden. So we may train them with the turnings or sitting up with the support or wheelchair mobility. So some early gains may give some confidence in the patients. So whatever possible gain we can do, that from that we have to build up the trust. Then we have to try to do better in the given clinical situation. Hello. Hello.
Yes, sir. Very valid point, sir. So, like moving on to next, Mr. Tarun further comments that we can set short-term and long-term goal being realistic. For example, bed sore can be managed well, but overall prognosis is inevitably poor.
Improvement in range of motion, but so management, pain and anxiety can.
Sorry.
Yeah, but long term has to be very realistic, because we don't have the hope. We always keep a trust, but that should be known. So we can tell his family member, these are things you can achieve. These are the outcome we can achieve, and can prove it by pre and post treatment. But this will be a bit difficult. And of course, I think somebody has mentioned, give stories and telling the creating the WhatsApp group or somewhere the patient have got a chance to share and listen from others. Maybe a common sharing platform can be a, but if the person who is also sharing, if is on the last stage where he knows about his condition, breaking the barrier could be opposite to the, I mean, it can backfire us in case the person who is sharing is talking about. Thank you.
Thank you, Mr. Tarun. And Dr. Vandana Patel has put on this chat box that we can have a psychological and vocational counselor for the patient. The vocational training will be provided according to the mental, cognitive, and educational background. Then the placement officer will help him getting a job, particularly the sitting job. This will help in improving the financial status of the patient. And we have to tell that this time will also pass. Don't lose hope.
No offense, Dr. Vandana, but do you think with the prognosis of less than 6 months, this is going to be of any help, especially from the palliative care point of view, where we are focusing right now on palliative care? Mr. James, what is your opinion on that?
Yes, I think I can. We can look into it later on. But for the time being, what we have to look into his primary concerns, and we have to try to resolve it. Like as Dr. Gargi has mentioned, he's a bedridden. We have to. They are already doing the positioning and all 2 hourly. So now we have to try to make him sit like in bed itself with the long sitting, but but she have told that he's not cooperating with the Taylor's brace. So we can look into some other alternatives, like some lumbar faucet and all of it possible. And if we can try to make him sit at least in the bed for long sitting. It will give him some psychological well-being and all.
Yes, thank you all for suggestions.
If you have any other comments or any other doubts, you can put it in our WhatsApp group and we can discuss in that group later on. So it's now it's time to wind up the session. Thank you, Gagi, for the wonderful presentation, and I thanking every participants for their comments and valuable points and their participation. Over to you, Ms. Sri Priya.
Thank you, Mr. James, and thank you, Dr. Gagi. Yes, we do understand that the breaking of bad news, especially in this patient, is really crucial. And in case you do require our real-time support, we do have a free telehealth consultation. Plus, you do have the contact details of Mr. Biju Raghavan from the case presentation. Unfortunately, since he had to handle one patient, he had to leave the meeting earlier. So I believe you can also get in touch with him to get a proper solution for this situation. So with that note, this is Shripya, along with Mr. James and Mr. Vaishnav, signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, be happy. Take care, bye-bye.
Bye. Thank you.
Thank you.
Thank you, ma'am.